It's a great photo. I think we can all agree about that. Blood flow restriction is something that's becoming really, really popular, especially in the United States, and I've heard it's the same over here. It was studied for quite a while in Japan, but it's starting to make its way into clinics and a lot of sports teams as well. To kind of just start off with what is blood flow restriction, what we mean when we say that is we're just restricting blood flow into the muscle and largely including it out of the muscle during the rest period. And doing this has been shown to result in beneficial adaptations to both skeletal muscle as well as bone, potentially bone. Definitely skeletal muscle. And this has been observed across a wide range of populations, young, old, trained, untrained. Pretty much everywhere we've looked with muscle, it's been seen to show some benefit. Just to kind of give you an overview, I like pictures, try to describe what we're actually doing here. So during normal exercise, you have arterial inflow into the muscle, then you have blood flow out of the muscle. What we do is we'll apply a cuff to the top of either the arm or the leg, and in our lab, to set the pressure, we'll take the cuff up into the lowest pressure of which there's no flow, which we call the arterial occlusion pressure, and then we'll take a percentage of that. So right here, there's no flow going in, no flow going out. So we'll apply, let's say it's 100 millimeters of mercury was the arterial occlusion pressure, we'll set it to 40. So we have some flow going in, and in rest, not a lot of flow going out. And what happens is you start to get some venous pooling, and there's some suggestion that there might be a cell swelling effect from this. So it goes over, makes the muscle swell, which has been linked in some respects to muscle protein synthesis. With continued exercise, you get a production of and accumulation of metabolites, and there's some thought that this can lower the threshold to recruit these higher threshold motor units. Okay, so this is so you kind of have an idea of what we mean when we're talking about blood flow restriction. And this is blood flow restriction for a short period of time. So we're applying blood flow restriction for minutes, not hours. Okay, that's an important distinction, particularly when we talk about safety. Okay, now just some history. The methods of blood flow restriction from Japan were generalized for public use back in the 80s. The first actual published paper, to my knowledge, was Shinohara, published in 1998, published in the European Journal of Applied Physiology, and it was looking at the strength adaptation to blood flow restriction in combination with exercise. The first mechanistic study at the fiber level, to my knowledge, was published by Rasmussen's group in 2007. Now, I won't talk about this too much because we have a whole presentation on it, but I think it's important to at least note that it is a relatively safe stimulus, and when you compare it with traditional exercise, it appears to be pretty comparable, if not a little bit safer. So the two big concerns that commonly get brought up is, does it augment muscle damage and does it augment blood clotting? And neither one of those appears to be the case, but you'll hear much more about the safety in our last presentation today. Now, when I discuss blood flow restriction, I try to separate it into three distinct phases. So we have resting, so just applying blood flow restriction with no exercise whatsoever. Applying blood flow restriction with slow walking or low intensity cycling, and then blood flow restriction with low load resistance exercise. And these circles are just kind of what we think, just kind of broad mechanisms for how we think this might be working. So when we say swelling, we mean short-term swelling. So it's back to baseline within an hour. But what you can see is it appears to be kind of a stair-step adaptation. So there doesn't appear to be a lot of muscle growth with rest. There's minimal muscle growth depending on the population when you combine it with low-intensity aerobic exercise. But when we talk about adaptations being similar to traditional exercise, we're talking about low-load resistance exercise. We're talking about the far right. Okay? So the first one we'll discuss is blood flow restriction in the absence of exercise. Okay? So what they would do is they would lie down, we put the cuffs at the top of each leg, and we'll inflate and deflate through a couple cycles. Now, the first study to really show this was Takarada back in 2000. So what they did was they had blood flow restriction applied day 3 to day 14 post-ACL surgery. And they just inflated the cuff for 5 minutes, deflated it for 3, and they did this twice a day, and they repeated it 5 times. So they inflated for 5, deflate for 3, 5 times, twice daily. And what you can see is when you look at MRI measured muscle mass, the knee extensors, they still lost, but not quite as much as they did in the control. So the blood flow restriction attenuated some of that loss of the knee extensors. This was not observed in the knee flexors. When you look at function or strength, Kubota looked at this in 2008 using a very similar protocol, only they used 14 days of cast immobilization. They had a control group that did basically nothing. They had another group that did brief isometric contractions. okay? And then the last one was just applying blood flow restriction, very similar to what we had on the last slide. And what you can see is over a wide range of speeds and intensity, or isometric and a wide range of concentric, eccentric speeds, it seemed like the restriction of blood flow attenuated the loss. So you didn't lose very much for the majority of these speeds with the application of blood flow restriction, which means you maintain strength. This was not observed with the isometric training or the control. Okay, so it really seemed like applying blood flow restriction may be doing something positive, even in the absence of muscle contraction. Now, how? Good question. There's virtually no evidence on how blood flow restriction could be attenuating atrophy or strength losses in this phase. One study suggests that blood flow restriction may induce an increase in muscle cell swelling. So obviously, when you apply a cuff to the lower body, some of the swelling is going to be due to venous pooling. But we believe that that there may be some increase in muscle cell swelling because when you deflate the cuff, it's maintained for at least 3 minutes post, with a concomitant drop in plasma volume, which suggests roughly that there might be some cell swelling occurring. Now, cell swelling has been hypothesized to stimulate protein synthesis, inhibit breakdown. There is an animal study that just came out using repetitive blood flow restriction that did activate the mTOR pathway, which is linked to muscle protein synthesis. So we're beginning to get a little bit more data, but we need a lot more, and that was in animals. Now, to take it another step, Natsume applied blood flow restriction with E-stem. So let's say you maybe aren't able to walk or ambulate yet. What would happen if you applied blood flow restriction and then did low-level E-stem? So low-level meaning it would equate to about 5 to 10% of your maximum voluntary contraction. So they had one limb which underwent blood flow restriction plus this E-stem, and they had the other limb just do the E-stem. Okay, and what you can see is that muscle size increased with the blood flow restriction, and so did strength. And strength was maintained for a little bit, for the most part, and detraining muscle size was not. Okay, now the pressure here was set relative to the limb, and I'll talk a little bit about that later. But an important caveat here is that these participants were ambulatory. I don't know how well it would do if they were cast immobilized or bedridden like the other two studies. But there is some suggestion that E-stem could be effective. When we go to the second phase, where we combine blood flow restriction with low-intensity walking or low-intensity cycling, it's kind of a similar thing. We have just the cuffs at the top of each leg, and they're walking very slowly, or they're cycling at a very low intensity. Now, the popular very first study with this was published in the Journal of Applied Physiology by Takashi Abe. What they had young men walk at 50 meters per minute, so very, very, very slow. They did this 6 days a week, twice daily for 3 weeks. They did 5 bouts of 2-minute walking, 1 minute standing. And what you can see is, over time, the blood flow restriction group augmented muscle size as well as knee extensor strength. This was not observed in the control group. Now keep in mind, this is very slow speeds, and I think this might be a very population-specific finding. But if you have someone who can't do anything and they can't lift weights, it might make sense to have them walk slowly with blood flow restriction. They might be able to get something out of that, a little bit more than normal. Now, there's only one study with walking to try to explain that mechanistically. It was 6 young men, 20-minute treadmill walk. So one limb was under blood flow restriction, one limb was not. They took biopsies out of both pre and 3 hours post-exercise. Now, I have this highlighted because this is, as you'll notice, a protocol that's much more intense than what was used to observe adaptation. Okay, so it's very possible that this might not happen at very slow walking speeds. So I think we should keep that in mind when interpreting this. But what you can see is if you look at this, there was a trend to see an increase in S6K1, which is a marker of the mTOR pathway. And there was some changes in MAPK signaling as well, which would favor potentially changes in muscle protein synthesis. But again, I think this last point needs to be maintained, that we don't know mechanistically how this works using protocols that are actually used. Okay, that was twice the intensity that was used to produce adaptation. But anyway, potential mechanisms by how this would work, perhaps cell swelling again. There is an increase in EMG amplitude. The change in EMG amplitude does occur, but it's quite low compared to high intensity cycling. Now, this was taken over the whole bout, so it includes some resting, so it is a little underestimated. but you can see that the EMG amplitude is quite low, which might provide some explanation for why you do see some muscle growth and muscle strength in this phase, but not quite as much typically as you do with resistance exercise. When we go to the phase where we talk about seeing robust muscle adaptation, this is the phase that we're discussing. This was a piece that they did on our lab in Sports Illustrated. This was one of my students. This is what it would look like in the upper body. So you've seen what it looks like in the lower body. Upper body is the same way, only you apply it to the top of the limb and you train with a light weight. A study done at the fiber level looked at 10 young men, very high frequency protocol, 23 sessions within 19 days. They did 4 sets to failure with blood flow restriction, then matched it with 20% with the control group. And what you can see is that the type 2 saw an increase in muscle size as well as type 1 fibers. I'm only showing you type 2 here though. You can see a little blip here in the control group. They attributed this as cell swelling, and they confirmed that because post-exercise it went back down to baseline. Okay, whereas in the blood flow restriction group in both type 1 and type 2 fibers, it's maintained up to 10 days post-exercise. So this increase in fiber size is not just a short-term effect, it's chronic. And it had a concomitant change in strength that was not observed in the control group. So again, this is producing adaptations similar to that of high-load resistance exercise. When we go to try to explain this, again, we think cell swelling might be having some benefit here, but you also get a big accumulation of metabolites. And this metabolic accumulation, due to the pooling, might be very important for augmenting this EMG amplitude. So recruiting these higher threshold motor units to get them to adapt. And if we look at EMG amplitude, this is 30% to failure, no blood flow restriction. This is 30% non-failure with blood flow restriction and high-load exercise. And what you can see is that all of these produce high levels of EMG amplitude. And all of these have been seen to observe similar changes in muscle size and strength. Albeit 30% to failure takes a tremendous amount more volume, okay? A last potential mechanism which might be important when we talk about satellite cell activation is it gives perhaps a hypoxic-like stimulus. I don't want to say it's necessarily hypoxia, but hypoxic-like. Now, how do we go about best applying blood flow restriction? Now, this is something our lab has spent a lot of time on, probably the past 5 or 6 years. And there's 3 points that I think are important. And this will be things that we'll cover again and talk a lot more in depth about, or at least the practical side of it in the workshop tomorrow. But I think it's very important that we make the pressure relative to the cuff width used, making the pressure relative to the individual, and does cuff material play a role? So these are two commonly used cuffs. Not only are they different in width, but they also differ in material. One's nylon, one's elastic. Are there differences? When we look at cuff width, it's been well known for years in the surgical literature, as well as well known for quite a few years in the blood flow restriction, that a wider cuff results in a greater restriction at any given pressure. So when you look at this image right here, it takes a lot more pressure to cut off blood flow with a narrow cuff to a wide cuff. Okay, and this has been seen in the upper body as well, across a wide range of cuffs. So if you use a wide cuff, you need to use a lower pressure by default. And that becomes important when we talk about, when we look at research and we talk about prescribing this to people. The pressure needs to be prescribed based on the cuff width used. It also needs to be prescribed to the individual. So when we talk about making it relative and you don't have a way to check the pressure, how do you make it relative? And quite simply, it's basically the bigger the limb, the bigger the pressure. So this is true in both the lower body as well as the upper body. So in the lower body, thigh circumference is the biggest predictor of arterial occlusion. Arterial occlusion meaning the lowest pressure it takes to cut off flow. This is showing a part correlation coefficient. What this represents is the amount of unique variance explained, accounting for the other predictors. So in the lower body, circumference is explaining the most unique variance. Now, when you add in composition, so muscle cross-sectional area or fat cross-sectional area, estimated by CT scan, it doesn't explain any additional variance. So the practical method of just taking the circumference predicts the same. When you look in the upper body, it's pretty much similar, although brachial systolic blood pressure is also a predictor, which is not that surprising, given it's kind of measuring something similar. Okay, so in principle, a bigger limb requires greater pressure. What about cuff material? So we know that there's differences in cuff width. What about the material? So when we took a 5 centimeter elastic and we compared it to a 5 centimeter nylon, Different material, similar width. When we looked at rest, it produced a pretty similar arterial occlusion pressure, so it wasn't different. When we looked at exercise, it was hard for us at the time. We didn't have a way to do this. We do now, but we didn't at the time on how to measure blood flow during exercise. So what we did instead was just use an indirect marker of blood flow, so workload. So we just had them go to failure. And when we did this, there really wasn't any differences between the elastic and nylon, giving us some credence that if they're of similar width, they're going to give a similar response, at least in the lower body. When we look in the upper body, it's not coming, there we go. In the upper body, it was a little bit different. So we couldn't get a 5 centimeter elastic. The size they use is a 3 centimeter elastic. When we compared the 3 centimeter elastic to 5 centimeter nylon, there were actually kind of big differences, with the elastic taking a lot more pressure to cut off flow. I don't think that this can be described by that 2 centimeter difference here. I don't really know what's describing. I think it might just be how it expands. But when you make it relative to the cuff, so we took the pressure and we took 40% of it. So when you do this, obviously 40% is going to be a lot more with the elastic. When we applied 40% arterial occlusion, so made it relative to the cuff used, and we did the same thing, repetitions to fatigue, it was the same across, which gives us some indication that if they are slightly different and you make it relative to the cuff, despite differences in material, it should give you perhaps a similar response. So why does this even matter? And this is something that rightfully gets asked to us on a monthly basis. Because if you look through all of those studies that I showed, produced benefits in muscle adaptation, so they all kind of increase muscle size and strength, almost none of them make a pressure relative to the person, right? They all apply the same pressure to everyone. So why should I care, right? Very important question. One, replication of findings. It's very, very hard, and I'll show you that if you apply this different pressures to this, or the same pressure to everyone, it's going to be a different stimulus, okay? It may produce the same muscle adaptation, but the cardiovascular response and everything else could be different. There's also perhaps an increased risk with higher pressure without an increase in adaptation. This was something that was brought forward by Marty Springer when he was talking about maybe we should take some caution before we move into the clinical setting with this. And he was talking about applying a high pressure and his fear of the blood pressure response, which I'll talk about in the next couple slides. Lastly, wide cuffs may attenuate increases in muscle mass underneath the cuff. Okay, so we'll talk about all these reasons why I think it does matter. So the first one, there is a greater blood flow restriction will increase the cardiovascular response. So when we looked at this, we had 27 participants. We looked at a wide and narrow cuff. This is estimated blood pressure at the heart. We did knee extension exercise, and we inflated the cuff to the same pressure. Okay, so if you remember from a few slides ago, if you inflate a wide cuff and a narrow cuff to the same pressure, there's much greater restriction with the wide cuff. Okay, and what you can see is that Marty Springer was right. It does matter. There is an augmented blood pressure response to using greater restriction. Now, I think it's also important to talk about the magnitude of the change. So this is not alarming elevations in blood pressure, but it does augment it over a 5 centimeter cuff. It's also important to note that it does come back to baseline within 5 minutes. Okay, so if you're dealing with a population where it might be important to control blood pressure or to not have enormous spikes in blood pressure, this might be an important consideration to make. Now, what about the actual blood flow response? This is a paper that we have under review where we actually looked at blood flow instead of inferring it. And what we looked at both men and women, but we had one group that just did no blood flow restriction, so just 30%. Another group applied 40% arterial occlusion and 80% arterial occlusion. So important things to note. One, blood flow does elevate over baseline. So that it shows that there is an increase in arterial flow to the limb, even at high pressures. It's also important to note that 40% arterial occlusion is not necessarily a 40% reduction in blood flow. It's just a 40% arterial occlusion, so 40% of the pressure needed to cut off blood flow completely. It's not a linear response. And if you look at post-set 1, 40% blood flow restriction is 20% less than no blood flow restriction. 80% is 70% less. And it's a similar story in women. Now, if we know that high pressures result in marked changes in blood flow, and they also have marked changes in cardiovascular response, do you actually need to use them? And the answer, as it commonly is it depends. So when we looked at the upper body, this was one of my students, she did this, 30% 1RM, We did an 8-week study, and we looked at muscle mass across multiple sites as well as strength, and we looked at 40% versus 90% arterial occlusion. Okay, and what we found is that the muscle adaptation was the same. Across everything we looked at, it was identical. Now, Laurentino's group came back and looked at this at 20% and 40% in the lower body, and what they found is that at 20% 1RM, you did get something extra from the added pressure. So what it might suggest is there comes a point where if you go super low loads, maybe you do need higher pressure, but if you're around 30%, 40% 1RM, higher pressure is not going to augment that response. And this was true of muscle strength as well. What about attenuating growth underneath the cuff? Okay, so the first time that this was observed was a paper by Kaysen, and they did a 13 centimeter wide cuff inflated to 230 millimeters of mercury. So that's quite a pressure. That's quite a reduction in flow. And what they noted was that underneath the cuff, it seemed like there may have been an attenuation. Now, I didn't put too much stock into this, but then recently, Elfson studied 9 women, 18 centimeter wide cuff, and underneath the cuff, they noted a similar phenomenon. So there was muscle growth, it was just appeared to be attenuated. So we looked at this. Both of those were using the same pressure to everyone. So we looked at this using a wide cuff and a narrow cuff inflated to a high relative pressure, so 80%. And when we looked at this in the upper body, muscle cross-sectional area by MRI was the same between wide and narrow, and so was strength. Now, it could be, we don't want to write it off yet, but it could be that there's potential problems with just measuring one side. It could also be potentially different in the lower body. Both those earlier studies were in the lower body. But I do think it's an important consideration to possibly keep in mind that maybe underneath the cuff, the adaptation, at least with muscle size, may be attenuated. So who may benefit the most from blood flow restriction? Obviously, rehabilitation. Hopefully that's been made clear. You don't need heavy weight. You might not even need exercise at all. But some other ones, obviously the elderly. But one that I didn't give a lot of thought to until the past couple of years is astronauts. So they're trying to get to Mars, and the equipment that they currently use is way too big to use. So one of the avenues that they're looking at is perhaps blood flow restriction, and then athletes might also be able to see some benefit from this as well. So in summary, blood flow restriction increases muscle size and strength with low loads and intensities. Resistance training in combination with blood flow restriction likely works through a combination of mechanical and metabolic factors, meaning the metabolic is probably augmenting the mechanical. It's unlikely that the metabolites themselves are anabolic, and this might be the reason for the greater adaptation observed with low load resistance exercise. And lastly, in order to make it as safe as possible, and in order to make it so we can start replicating studies, the cuff pressure should be made relative to the cuff used and the size of the limb to which it's applied. So I'd like to finish by noting that we have been funded partly by the BioLane Foundation as well as the Japanese Society of Wellness and Preventive Medicine. I'd like to thank the Sportskongres for having me, and I'd like to also acknowledge my collaborators, Takashi Abe, Gilberto Laurentino, as well as all of my students past and present. So thank you.
Thank you very much, Jeremy. So as I said, please write down your questions and save them for the panel debate. Our next speaker is Per Aagaard, Professor Per Aagaard. I had the pleasure of Per as a supervisor during my thesis a little more than 12 years ago. Today, Per is a professor of muscle physiology and biomechanics with the University of Southern Denmark. And Per's research focus has been on adaptations in neuromuscular function and muscle morphology induced by exercise, but also with an emphasis on rehabilitation implications. So welcome, Per.
Thank you. And while we're trying to make this technique work, electronic, no occlusion, but right now something should be happening. The background for me to go into this field here was one student coming to me, I think 6 or 7 years ago, and asking me if we could try to do some experiments with this new training technique, which was called Katsu training at that point in time. And I was very skeptical. I'm still a little skeptical, so I will try to invite all of you to stay skeptical and to keep that in mind when you want to ask questions about this technique, because we still need to be skeptical about it. But all this being said, I think as you just saw from this presentation here, there seems to be a lot of potential in this particular technique here, in the sense that we're able to load muscles and tendon with quite low loads, low intensities that normally wouldn't really make muscles grow. But in this case, with the concurrent occlusion of blood flow to the muscle, something seems to be happening. And like we heard in the previous speak, we are trying very hard to figure out what it is, but for sure, it's very challenging for basic scientists to find out that what we thought about muscle growth really doesn't fit into the scheme. We are learning a lot here. And I think using this in clinical medicine and in rehabilitation, this is a huge field that could open up with a lot of caution, of course, that eventually could open up in the years to come with a lot of help from you and the way you're going to use this eventually in your practice with various types of patients. So this is basically a summary that sums up half an hour of talk that summarizes some of the studies that have shown that we can have amplified or greater muscle growth if we apply low resistance occlusion training compared to free flow training. And there are also some studies showing increased endurance capacity. There are some studies showing that the explosive strength parameter can be increased. Funny enough, it really doesn't happen right after we stop training. We need to wait for a little time for this rate of force development ability to come in play, kind of saying that maybe this training is kind of stressful to the muscle tissue or maybe the nervous system. We need some restitution to make rate of force development, explosive strength go up. Maximum muscle power also increased, and in this single case study, postural balance and mobility also increased in a patient here, along with an increased quality of life. So before we'll try to present some of the studies I haven't been able to recover, I just want to speculate a little bit together with Jeremy on the various mechanisms in there. And I won't go too much into the IGF-1 production or the growth hormone or the myostatin expression. Myostatin is a negative regulator of muscle growth, but I want to have some focus on the muscular stem cells. Because from a rehabilitation standpoint, increasing the number and the activity of myogenic stem cells would seem to be very advantageous if we want to accelerate or speed forward rehabilitation in muscle tissue. And some of you are probably familiar with these muscle stem cells or satellite cells, which are normally lying around the muscle fibers, dormant, sleeping. And when you start exercising or the muscle tissue is injured, these satellite cells become activated. And most of these cells go back into sleep, actually, and lies there and wait for the case that some of these fibers might be damaged, in which situation that these satellite cells or stem cells will come into play and hugely increase their activity, fuse together, and maybe form new myofibers to repair those fibers injured. But the case we're talking about here, I think, in the use of blood flow restriction in athletes or patients, is the donation of myonuclei to these fibers that are growing in size. Because this is also an effect that happens with these satellite cells. They are having a fusion with the muscle fiber membrane and donating their single nuclei, meaning that we have more DNA material inside the fiber as a result of this activation of satellite cells. And the reason why I want to mention this is because it turns out that using this blood flow restriction is one extremely effective tool to increase the number activity of muscle stem cells. In other words, donating myonuclei and increasing the basis for muscle protein synthesis in there. And this is kind of a rare study. This only 3 weeks of training, and those areas that you see here, Jakob Nielsen was the main driving force. You see him here, and you see the pain in his face when he works at this 25-30% of one repetition maximum to failure. And this is the number of training bouts in each week. So each weekend we had time off, and in fact also this Monday no training because we took out a lot of biopsies on that day, and we waited After cessation of training, we waited 3 days and eventually another 10 days to take out biopsies to avoid the swelling phenomena, which for sure is in there. And looking at this high frequency type of training, the changes in satellite cells was quite extreme. Only within 5 days of training, we see a 300% increase, both in type 1 fibers and type 2 fibers, in the number of satellite cells in there. I'd say that normally you would have, I say, half a year of extreme training, and only those subjects who have the genetics to respond to that would show almost the same increases. Here we have a completely uniform group of young males, both responders or non-responders, and they have on average 300% increase in the number of satellite cells. I think it's a shock phenomenon. But if we wait for another 10 days, both for type 1 fibers and type 2 fibers, so getting rid of the stress phenomena and the swelling, you still see 160%, 150% increase in the number of satellite cells in there. It's a huge upregulation in there, probably because the training is very stressful. And what what these satellite cells are doing is they are contributing to this quite extreme muscle fiber growth. 40% in the first 5-10 days of training. Again, you would normally have 6 to 12 months of heavy resistance training to make this happen. We see this in only a few weeks of training. And if we wait for 10 days following the final training bout, we see increase of 30% and 31% in type 1 and type 2 fiber areas. So there's a huge anabolic stimulus in there, and it's got to be extreme because it's producing extreme muscle fiber growth in very, very short time. Maybe from a rehabilitation standpoint, this high-frequency training may be interesting for you working with intensive rehabilitation in athletes, because you could have, say, your athlete in your clinic for 3 weeks, and you might achieve results somewhat comparable to this. Now, we think that this huge increase in satellite cell number represents some sort of myogenic priming, so increasing stem cells and making them donate their nuclei to the trained fibers, increasing the DNA content of the skeletal muscle, got to have some huge potential implications for the anabolic response to this low-level exercise. And of course, if you have very big athletes and you want to make them even bigger without the use of testosterone and banned substances, this could be one way of going. But this lecture deals with patients, and I think we have even more exciting possibilities here, in the sense that we can, in the very early phase, where athletes would not be able to tolerate high loads as effect of the training we would like to apply, we could still apply kind of very low loads, or maybe even just passive occlusion, as you just saw, and we might still preserve or prevent muscle atrophy in this phase of following severe injury. So we think, especially in ACL patients, there might be a role for this type of training. And I really like this graph from Loenneke paper in 2012, where this is the normal progression pattern you have with severe injury, and we have bed rest or immobilization. Normally what we have is a loss in muscle mass. Eventually, some days or maybe weeks later, people are able to walk, certainly not anabolic stimulus, so we might lose even more, or may have stabilization for the loss in muscle mass that we have. And eventually, low loads can be used, and really not much of anabolic stimulus, but maybe a little stimulus for muscle growth there. On the other hand, if you have the occlusion in there, putting on occlusion, preventing muscle atrophy, even in the passive condition, walking, as we just saw, at low intensities for 5 by 5 minutes, maybe every day, maybe every second day, could produce actually muscle fiber growth. So not losing, but in fact increasing muscle fiber size there, and eventually going into a more advanced rehabilitation phase, putting on the weights. And despite the fact that we need to use low weights to protect the ACL or whatever structures that have been injured, we will still have a strong anabolic stimulus on the muscle fibers, and hopefully also tendons, due to the fact that we have this occlusion and this hyperactivation of satellite cells. So in the rest of my talk, I want to focus on some different patient groups that papers have come out, and and shown some positive effects on ACL reconstruction, myositis, patients who have a severe loss in skeletal muscle mass, hypertension patients, and osteoarthritis patients, and finally, if we have the time for it, also metabolic syndrome patients. You can actually find these papers out there. They are not easy to find, so if you want to have copies, you can't find them, shoot me an email. I would be very happy to send copies of the slides as well as the papers if you have a need to look into this for yourself. So this is a classical study which I think we just heard about it. Jeremy just talked about this passive occlusion, where this is just a single day. This is performed for 2 weeks right after surgery, a reconstruction of the anterior cruciate ligament. So twice a day, they have this passive stimulation in the morning and again after lunch. And the passive stimulation is a 5x5, I believe, inflation of the cuff, resting, and then deflation and reflation once again. Here you see the different, the protocol, the 5 minutes of occlusion and the 3 minutes of rest in between. You see the pressures are high to begin with, and by the end of the 2 weeks training, they are even higher. I think this is also a matter of getting used to the pain, why they have this progressive increase in pressure in there. But what happens, and we just saw a few minutes ago, was in those guys exposed to blood flow restriction passively, the loss in muscle size in these 2 weeks following surgery was much less, of around 10% on average for the different muscle groups compared to those guys getting the sham intervention. So basically just lying there, not inflating these pressure cuffs, but just lying there for sham treatment. So you see that the 20% increase in the anatomical area of the quadriceps that was seen in the free flow or the non-intervention group was, prevented for 50% effect. So they concluded that the occlusion stimulus just passively applied is very effective in diminishing the magnitude of disuse atrophy in relation to ACL reconstruction, and they suggest that this might be very useful in the post-surgical phase in at least these patients here, maybe also in other people, bedridden old people. So another study came out. There have been a few studies out now, and they are using different active contractions concurrently with occlusion of blood flow. And they're using a constant pressure here on 180 millimeters mercury. And they have a high frequency of training, I'd say, 6 times a week, so only Sunday off. And they had 2 groups, one with restriction and one doing exactly the same exercises and not having restriction. And what you see here is that following these 4 months of training, so this is kind of strange data. Well, and that might not be. This is the size of the muscle, the surgical operated side compared to the non-operated side in each subject. So what happens here in the sham group, in those not having restriction, is there's about 88%, so we have a ratio of 0.92, so an 8% reduction in the area on the surgical side compared to the healthy side, whereas in those guys working with occlusion, we see no decrement, but a 1% increase. I say this is probably not statistically significant, but there is a difference between these 2 relative changes here. So again, the atrophy induced by surgery was fully prevented by this active regime for 4 weeks. And also, what happens here, if you look at the strength of these guys, which saw some quite marked changes. So this is again the ratio between the surgical side and the healthy side. So here meaning that in those guys not getting occlusion, only 55% of the strength on the surgical side after 4 months of training or rehabilitation compared to the healthy side. Whereas those receiving occlusion, we have a 76%, 77%, 84% strength left. Again, you have the isometric, you have the fast and slow concentric strength here, and you see that this is very pronounced both for the quadriceps and also for the hamstring muscles. And these indicate whether there are differences between these 2 interventions here. So again, loss in strength was very effectively prevented by this type of occlusion here. We have tried to do similar sort of similar results here, only with a stronger focus on the strength training, and randomizing a few days after surgery people either into standard rehabilitation or into standard rehabilitation with the addition of blood flow restriction. So in all the strengthening exercises, knee extensions with very low loads, restricted range of motion and so on, and these guys down here, they were receiving blood flow restriction using a occlusion pressure of around 110, 120 millimeter mercuries. And what you see here is before and after 3 months of rehabilitation. Here you have the blood flow occlusion, and here what you see here is the standard rehabilitation. So there's a difference here between the relative changes in those two limbs. And the same is true down here for the hamstring muscles, and down here you see a 3% for the total thigh volume, so to speak. We see a full prevention of muscle atrophy in those guys exposed to blood flow restriction, whereas those going into the standard rehabilitation without turning up the pressure, we see a 6% decrement in the size of the thigh muscle, and this is following 3 months of training. So there seems to be something in there for sure. We look at the strength, it pretty much mimics what goes on there. So these scores, so the functional subjective scores, which many of you are familiar with, show perhaps even the most exciting results. So here are the different weeks of training, and so the light gray bars are those guys receiving blood flow occlusion, and if you look at the pain, it's gradually recovering in those guys getting traditional rehabilitation, but what we see in those guys using the blood flow occlusion, we see a huge accelerated, amplified response in the early and later weeks of rehabilitation. In this particular case, in terms of pain, what you see by 12 week is pretty much comparable between the two groups, but while you get there, in the weeks getting there, much less pain is experienced by those guys receiving occlusion training. The same thing goes for the symptoms, activities of daily living. We see accelerated scores at 3 weeks and 6 weeks compared to those observed without using occlusion. And also here, participation in sports and so on. And here for the quality of life, even comparing what happens at 12 weeks, there is a difference between those guys exposed to the occlusion training, which you see over here, higher scores compared to those guys getting the free flow stimulation, basically the standard rehabilitation. So it does seem to make a difference, even evaluated with these highly subjective scores, which by the end of the day might be the most important measures that we have evaluating the effect of this intervention here. So it seems with these preliminary data, here we have only 12 subjects in there. We are still missing another 10 subjects to go through this protocol, but it seems from these data, it does seem to be applicable in these reconstructed patients, and it does seem to accelerate recovery in muscle mass, and especially in perceived knee joint function and health. So it might be a suitable rehabilitation method in these patients here. There is another study coming out just recently showing that, in fact, this regime may not reduce muscle atrophy during anterior cruciate ligament reconstruction. And I think it's fair to mention this. You know, the scientific literature is not always, they don't agree on all things. Here you see the pressures they are using, going up to 180 millimeters, and it's quite intense, twice daily, and for 2 weeks. So no weekend off here, and it's kind of very low forces going on during the exercises they are doing, but they have very high number of repetitions in there, and the controls, they are doing the same training, only no occlusion in there. And if you look at the decrement in area of the quadriceps muscle, it's pretty much, in fact, it's exactly the same between those doing the blood flow restricted training and those exposed to the control. So here, no additional effect of applying blood flow restriction. So there's the conclusion they have no reduction, no preservation in quadriceps cross-sectional area as a result of blood flow occlusion. So there are, I think when we talk about the rehabilitation in ACL reconstruction, there are some contradictory results. I mean, there's a pretty large number in favor, and there's this single study from Norway not in favor of using blood flow restrictions in there. But I think maybe the twice-a-day training with the combination of, I mean, it's not passive, they're actually also exerting active forces in there. So it's quite aggressive, and maybe it's a little bit too much on the myofibers in there. It might add up the stress response in those fibers. And we are just about to publish data from our high-frequency training study in which we can actually see on the muscle biopsy analysis that in many fibers we see single sites on the muscle membrane that look stressed. Basically, it does have stress signs of focal micellar stress there. We are looking at heat shock proteins 27 and on macrophages located at certain points in the membrane, and they seem to be quite heavily upregulated in this high-frequency training, at least in our hands. And it might be that we want to be careful with certain patients not to make it too intensive and too aggressive. Twice a day might be, in fact, too much in the rehabilitation in ACL reconstructed patients. We don't know yet. We need to figure out the precise dose-response relationship here. So in myositis patients, these are patients who have this inflammatory disease in their skeletal muscle, and they might have what corresponds to 10% of the area of the muscle, which a normal age-matched person would have, maybe at just 5%. We have been taking biopsies in these patients, and some of them might have a quadriceps corresponding to the size of your little finger. Of course, we will not take a muscle biopsy in these patients. We go somewhere else and take another biopsy. But so there's a severe muscle loss in here, and Anders Jørgensen, who will be here tomorrow, sits right here, and he will be working in the workshop, bringing our equipment. So if you like to work and see how it works, come and visit Jeremy and Anders and the other guys tomorrow. And we had this 70-year-old male who had myositis and went into this 3 months, 12 weeks of BFR training. You see, it's a low frequency, 2 sessions per week. I think initially we planned 3, but found out that maybe that was too strenuous on this particular guy. And here you see the reps he was using, 3 to 4 sets to failure. And this is the rest period and keeping on the cuff in these exercises, which you see down here. And what happened following these 3 months of training was that maximum horizontal gait speed was increased, so function was improved, and also maximum isometric strength, rate of force development, and muscle power was improved in the weakest limb, and also asymmetry, so differences in strength between limbs, which is a predictor of falls. By the way, increased asymmetry, increased risk of fall. So asymmetry also decreased because this mainly happened in the weakest limb of this particular person. So it seems that from this single case study that it is possible to apply this training regime to severely affected patients with very severe muscle loss, and we can still improve function. And in fact, also muscle size. This is another single case study coming out in 2010, MedScience Sports and Exercise. One single person, 3 months of training, and also showing increased strength, postural balance improved, but also quadriceps muscle size increased by 5% measured by MRI. And I think the final, the last observation, increasing skeletal muscle size, is extremely important. Bringing back muscle mass, thereby improving function, which also was reflected in this particular study in here. This is a group of patients with other types of myositis, and I won't go too deep into it, rather just mentioning that actually muscle size could be increased, strength could be increased, and function timed up and go, and timed stands from a chair, which I think are the very important functional tests that we have, were also improved in response to this occlusion exercise in these groups of severely affected patients, very weak patients. So hypertension, we are applying occlusion in there, and as Jeremy showed you, it probably will affect systemic blood flow while we're doing the exercise. So is it dangerous to use this type of exercise in hypertension patients? It might be. But anyways, this study was courageous because they looked at hypertensive patients on medication, women, and for 8 weeks, 2 sessions a week. And here you see the pressure here, 70% of individual systolic blood pressure. And what they were able to see in those guys, so they perform wrist flexion, blood flow restricted over here. And here you see the decrease in systolic, diastolic, and metarterial pressure. And all of those were significant. Those doing the same exercise with free flow, so no occlusion, no changes happened at all. And those doing no changes or no training at all, again, no changes happened at all. And they have this nice graph. What you see here is the decrements, so 10% decreases in pressure, and those guys having the occlusion, and just training a very, very small muscle group, still affecting whole body systemic blood flow pressure quite dramatically here. So it did have an effect in lowering pressure. So I just want to jump directly to the conclusion. There are 2 studies in osteoarthritis patients showing positive results in women. Again, pressures, but strength improving more. Power did not improve more in those women receiving blood flow restriction, whereas exactly the same group looking at males could not see the same benefits in male persons for some very strange reason. But again, no major improvements or no major advantages of having the occlusion, but they were only looking at guys or patients for 4 weeks of training. Metabolic syndrome patients also seem to have a measurable effect in here, and they had different types of disease in there, these patients, and this study has to be taken a little bit cautious because it's the Journal of Katsu Training and they did not have a control group. But what you see over here, in the hypertensive patients, 12 out of 18 patients had improvements, which was reductions in blood mean arterial pressure in terms of glucose, long-term glucose control improvements, and also in high-density lipids in the blood, reductions of 14%, and obesity, 5 out of 9 responding, and a 12% decrease in body fat percentage in this particular group. So it might be useful also in metabolic syndrome patients. So just to sum up, we might have a broad applicability of BFR training in various patient groups. For sure, myositis patients seems to benefit from having this low-level occlusion training. ACL reconstruction also seems to benefit, although there are some controversy in there. I think you can train too much, can actually be applied to these patients in there. And also in hypertensive patients, there seems to be a positive effect. And also, Jeremy and Loenneke have this single case study indicating that maybe bone formation, bone health, and rehabilitation could also benefit from this type of exercise. And these final data, metabolic syndrome, might also be aided or revealed by this type of low-resistance blood flow restricted training. But of course, the data out there are so limited, so for sure we need much more data in there. And most of all, I think we need your experience. So you guys working with the patients, getting experience, deciding what works and what doesn't, and feedback to the researchers. That's perhaps the most important thing we need to get going. So thanks a lot for your attention. Yes, and I'd like to introduce our next speaker, Hans Christian Heitkamp, please come up. So Hans Christian, he's a professor in sports medicine and clinical exercise physiology at the Institute of Sports Medicine from the University of Bandholm in Germany. Yeah, and your research interest, besides occlusion training, includes prevention and rehabilitation of cardiac disease and lactate kinetics during exercise, and also adaptations to whole body vibration. So, please.
Thank you. Where's it? Oh, yes.
Need this. Sorry.
Thank you so much. Dear Chairman, dear ladies and gentlemen, thank you for the invitation to Copenhagen. I was glad to be able here to be at this session because it's my interest, and I like to focus your interest now on several points. At first, this session is going to deal with rehabilitation or with chronic disease. Chronic disease is oftentimes accompanied by old people. So old people have not only one, but they have oftentimes several chronic diseases. That's why at first I would like to outline what influence this BFR training has on the muscles in aging people. There is not much literature on that point. Also, then I want to go to the side effects, which are in older people, of course, more to be seen, and at the end I would like to come to the safety points and contraindications for BFR training. Aging affects the muscle and in different ways. We can see that the muscle mass, and that is common knowledge, muscle mass is going down. On the other hand, primarily because of FT, fast fibers go down to a large percentage, and the fiber area of FT goes down too, while the relative percentage of ST fibers goes up, and the ST fiber area remains about the same. The oxidative capacity also goes down. And there's also the theory that there's a transfer from FT fibers to ST fibers by a change in innervation, and so that's why we find more slow twitch fibers. That's why it all quick movement in old age is not possible anymore, because so much ST fibers are away. And now, of course, because we have old people, then it's interesting to do blood flow restriction training, because Loenneke and co-workers, they showed that the FT fibers are at a lower intensity activated than without blood flow restriction, and that the FT fibers are more activated than the ST fibers. And this is important, of course, when we do blood flow restriction training with old people. And I tried to figure out in the literature what was to be found about the effects in old people for the muscles. And you can see that the growth hormone increase has been shown in 71-year-old persons, in 70-year-old persons here, and also with 71-year-old persons. So with old persons, you find an increase in growth hormone, you find an increase in muscle protein synthesis with mTORC1 at the age of 70 years. And this is important so that you know that there is evidence that it's worthwhile to do blood flow restriction training with elderly people. Here you can see the typical setting as we saw before, with the blood flow restriction apparatus set here, and we see this is resistance training, and we find, and this is the next point, we already had this the first side effect, which might be even dangerous, is the increase in blood pressure. And that comes because we find here again, we have now here the occlusion here at this point at the arm. You can see that the afferent from the muscles now increase the sympathetic activity, nerve activity, they increase the heart rate, the cardiac output, the contractility, and above all, the blood pressure at the same time, because of also the arterial resistance is increased. And these are important effects with Spranger et al. Just mentioned in 2015, because this sympathetic overflow might be different from person to person. The efferent signals may be overflowing in some person, and then you might get serious side effects because of the increase in blood pressure. You can see when in this paper there was a comparison now in young 30-year-old persons and 66-year-old persons, and you see the mean blood pressure here, and this is 3 minutes of occlusion training, BFR training, and you can see that the 30-year-olds have an increase from about 90 to 150 mean blood pressure. And on the other hand, we compare this to the 12, 66-year-old, and you can see the increase is in some of them from about 100 to up to 180. So you have to take in account, if you train with older people, that the increase in blood pressure may be much higher than with younger ones, that is 30 years old. And while on the other hand, the calf blood flow is about similar, and also the calf vascular resistance acts in a similar way. There's not much of a difference, but it's important to notice that the blood pressure increase is stronger in older peoples. And this study is similar. We saw also from Brazil, from Pinto, and we can see they compared hypertensive women, 18, age 67 years old, and they were under medication. And you can see 3 sets of training. And after every set, the increase of blood pressure, originally they were well treated, 140 over 70, and that's this diastolic value. And you can see that the increase under 20% BFR training with an 80 centimeter cuff is about set to 200 and something, that's about the same, 210 about. And on the other hand, the same persons with 65%, 1 repetition maximum, that is a higher intensity, though not the regular, which you find with 81 repetition maximum %. And you can see that here the reaction, again, the same, original 140, the same persons, and you can see that the increase in blood pressure is almost the same. So you can see there's no advantage from BFR training for hypertensive women in this case, whether they do BFR training with 20% or whether they do it with 65% without blood flow restriction. So this is done individually. It was a good point. We just heard that it should be individual. Occlusion was 80% of complete occlusion, that was individually adjusted, the occlusion pressure. So this is another important view. Now I come to the regular side effects. On the most regular side effects I want to stress at first, it is hurting. We didn't hear this before, but it is hurting. It's very uncomfortable. And I did some studies, and about in every study 2 or 3 or 4 persons dropped out or didn't want to take part in the study because it was hurting them too much. So this is an important point, that the pain is especially maybe for older people, for chronic sick people. That is, it's individual. You know, pain is individual, and in older persons, this is a regular. You have to you have to expect more than 10% bleeding, petechial hemorrhage, but that is disappearing. You can continue the training with the same amount of pressure, the same amount of volume. Then, nevertheless, those subcutaneous bleeding, petechial hemorrhage is going to disappear. It's interesting that it's more at the upper limbs than in the lower limbs that these bleedings occur. The temporary numbness is below 2%. This is rather seldom. That is also disappearing in spite of regular training, the continuous training. Also, the pain is going less and less with every unit you apply. But the pain is also decisive from which type of cuff you use. If you use a narrow cuff, the pain, you see mid-exercise, immediately post-exercise, the pain is much lower, about half as much on a 10-point scale in comparison with a wide cuff. There's almost 8, so double as much as the pain. So the pain one shouldn't neglect the pain is an important point. And also the pain is also depending whether we have now between the sets, we have 4 sets again in this study. You can see at the first 2 sets there's no difference whether you open the cuff in between the sets, but then later on the difference is there whether you opened the cuff between the sets or not. The pain is much higher if you keep the occlusion complete, but on the other hand, and it's discussed in science also, whether it's good to keep the occlusion during the total training unit, or whether you should leave the pressure down in between to make it more comfortable. I did one study with the intermissions here, so that they could, with older people, well, not old, but 55 years old, and they insisted on leaving the pressure down, and I didn't find an increase in strength in this training. I think it's not good to leave. We can discuss that later. To let the pressure out in between the sets. Most studies they were done, they had always the pressure 20 minutes continuously, even between the sets. So the other side effects are also discussed by you, Dr. Loenneke. We see that oxidative stress is usually expected with this type of training, but on the other hand, it's low repetition, low intensity, and so you didn't find any markers that would indicate an oxidative stress. So this is important also for people with cancer or any other serious chronic diseases, that this type of training is not leading to oxidative stress. Muscle damage, numerous studies were done, and were shown that there is no muscle damage, but I show now an exception on the next slide. And the nerve conduction velocity, you might think the arm or the leg is compressed for several weeks, for 3 or 2 times a week, that the muscle is going to diminish a little bit, and the conduction velocity is changed, but also the conduction velocity is not changed. But there, in literature, there are 3 examples for rhabdomyolysis, which is, of course, a very serious complication. 2 cases were in the literature from Japan, and one was for shortly also from Tabata from Japan, with 56,000 units of CK, and that was a person, and that's why it's not good for people who are overweight, sick. Was sick, the person, and the environment was very warm, and the training intensity was high, and then it came to this complication occurred. This complication is published last year, is something which one wouldn't think would occur, but it's extremely seldom. The next point is also seldom, but one has to account it, and that's why it's interesting that that post-operative so many studies are done, because the danger of thrombosis is after operations, after surgery, is not small, and so it's interesting that that the indication is seen there. But here we have in 12,600 reported trainees, we found only 1 case that had a venous thrombosis. In my own studies, I had a person training, and after the 2nd or 3rd training session, she called the next day that she had pain in the leg, and then she said that she had forgotten to talk about that she had venous thrombosis, before, and she had undersigned that she didn't have it because that would have been exclusion criteria, and she was then stopped to take part in the study. Fortunately, she didn't get another venous thrombosis. But venous thrombosis in the history, personal history, is a strong contraindication. On the other hand, there are several studies that prove that this type of training, even it's the same without occlusion, needs the fibrinolytic system is activated, so it's usually quite good, and also the regulation system is not affected negatively. Also, only one study that was not long ago in 2016 showed an increase in von Willebrand factor, which leads to more adhesion of the platelets. So that must be. I think we need some more studies on that. That could be a contraindication, and for old people. It's remarkable that we don't find any studies with people over 80 years, for example, in my view. Also, in literature, women aged 30 to 50 years have sometimes venous injury and indurations of the veins, but they disappear usually after 1 to 2 months, so that is not a serious side effect. And the Nakayami and co-workers, they emphasize that you should train older persons, the veins a little bit by pressurization and depressurization rhythmically before training, so that the veins are adjusted. There is no scientific proof for this recommendation, but maybe he is right in that. Also, one always should get safety information by a questionnaire asking for cardiovascular or neurological symptoms, cardiovascular history, family history, lifestyle habits like smoking or alcohol consumption. This is also important. And also, I didn't put this here, also the medication, especially if you have chronic ill patients, then the medication is important also. And this, I find, is an interesting total view of how you can find how much at risk a person is. The 5 points, if you have more than four points, then the person should not train with this type of training. A history of deep vein thrombosis, acute sickness or fever, blood pressure over 180 over 100, early post-operative period, and that's why this is discussed. It's interesting, but this is also, again, with older people, higher class arrhythmia or not treated coronary ischemia. Pregnancy, also pregnant women, especially in the later phase, should not train with this method. And also they get 3 points for varicose veins, prolonged inactivity, atrial fibrillation or heart failure, and if the blood pressure is in the 160 to 179 or 59 to 90. 2 points, people over 60 years, and with obesity, malignancy, hyperlipidemia, estrogen therapy, again affecting the coagulation system, estrogen. And 1 point for age 4 to 59. He wrote 58, but I think it should be 59. Women and overweight, BMI between 25 and 30 kilogram per square meter. And if you do a single training unit, you should observe those points, because you have trainees, especially maybe they are eager and they want to achieve much, so they start to lift the blood pressure, the tourniquet pressure, the BFR pressure, and this is not good because it should not happen hemostasis. Hemostasis would be a danger for thrombosis. So the tourniquet pressure should never be in that realm. And also the keen persons, they want to have much, you gain much, so they do an intensity overload. That is also not good. And always you should be aware of cardiovascular complication because of the pressure, exercise pressure reflex, as I showed to you, and no training with unknown patients, and the blood pressure should always measured in persons who had originally 140/90 at rest before you started. Diabetic patients should have a glucose level below 250 milligram per deciliter. This now I come to the conclusion. Blood flow restriction training is effective in older person that is over 60 years in increasing muscle mass and strength. I could show you also the markers of protein of anabolism in the muscles. Common side effects are pain, petechial bleeding, negative effects on peripheral vein are more likely to occur in older peoples, and but you can see that they usually disappear when you train continuously. Blood coagulation is not changed, and fibrinolysis is rather improved. And the rise in blood pressure, I think this message I could give you, is more strongly in aged persons, and hypertension is an important contraindication. And also the history of the deep vein thrombosis is important contraindication, and relative contraindications are obesity, estrogen therapy, and malignancy. Taking it together, I had to, it was my aim now to show you the possible negative effects, but taken together, it is a safe and effective training method also in old age and most likely in chronic disease when observing the recommendations for risk stratification. Thank you very much.
Thank you very much, Hans Christian. If I could have the presenters up here from a panel.
I have a question for you, Hans Christian. Thanks for a very nice presentation. So when I loaded up my slides, I was asked if it was okay to put these slides as PDF copies at the website.
Yeah,
probably you were asked the same question.
Yes, I had they are also.
Because I would assume that the table you saw on the risk factors, you would like very much to have a copy. I would like very much to have a copy of that.
And yeah, I wanted to have a handout, but I didn't know how many people were. I would have given that
but it seems that we will be able to download it from the website. And in relation to that scheme, what would be? So you had number of points. So adding, what would be the critical sum of points?
4.
Thanks.
So at 5, no training.
Yeah.
Yes, questions? There was one in front here. Oh, sorry. You go ahead, Thomas, and then up here.
Thank you very much for 3 really, really interesting presentations. Thank you very much. When we just talk about the scheme, Professor Heitkamp, it is that you said like 5 points. That was early postoperative period of. So actually, the studies that have been doing, especially in Per Aagaard's group, was actually be a contraindication. Is that true?
Yeah, well, I presume that you have to see relatively, because the age is important. I would like to know the age of all the interventions which you reported. Probably they were younger, like 20, 25, or those sports injuries, and then it will be okay. But you know, in connection with surgery, one usually wears stockings and gets special shots to avoid thrombosis, and so that is it's not easy. They have to find a right balance there.
I'm sorry, but could you just have another question, please?
Yes.
Thank you very much. That's for you, Per Aagaard. What I'm interested is about, individualizing pressure due to the knee or to the thigh circumference. So the ACL study that you're conducting at the moment, and the other studies you've been conducting, have you had the same amount of pressure with the same amount of width of the cuff?
We have had one common pressure for all persons, so definitely not ideal in relation to what Jeremy just shown. But we didn't have the technique to measure individually a level of the muscle occlusion, actual occlusion, arterial occlusion pressure, and then applying a certain, say, 80% of that, because of course we would have chosen to do that if we could have done so. But we chose an occlusion pressure of around 110 millimeters mercury, which for some subjects probably is perfect. For others, it's quite insufficient, and it's not optimal. Yeah.
And then there was a question for
Actually, it was the same question as the first question. So.
Excellent. I don't know who went first. Whoever gets the mic first. Okay.
Thank you.
Go ahead.
Sometimes you see people train with shoulder exercises with the upper arm strapped, and I was wondering, does that make any sense? And if it does, it has to be due to this systemic effect. Is there a systemic effect, and how much should we then expect of that? Just feel free.
I can start, and Jeremy definitely will have some comments too. There are quite a few studies demonstrating that when you look at muscles upstream to the cuff, so say if you have a cuff around your thigh and looking at the magnitude of muscle growth on the gluteus muscles or some other hip muscles, the same for the shoulders, you can actually see amplified muscle growth in those fibers who are not exposed directly to the occlusion of blood flow. So there is some factor, maybe factors being released properly, or they need to work at a high intensity to compensate for the fact that other muscles are becoming fatigued. Either of these two cases can be.
Yeah, I tend to side with the last point. I don't know how much about the systemic factors, but I definitely think. I definitely think when you restrict blood flow, you're fatiguing the triceps, and it's possible. That's what they're hypothesizing, that, for example, with the bench press, they'll say the chest will pick up the load. I'm sure it's the same idea with the shoulders, but I don't think there's a lot of data on the shoulders, but there are a few studies with the chest.
And the growth hormone increase is also important. That is systemic, so you can understand that you have a systemic effect.
I would disagree with that, but I do think that the activation is important.
Growth hormone doesn't have an anabolic effect on human myofibers in grown individuals. They do on the collagen tissue, so there might be some advantage on the extracellular matrix and the tendon tissue in there from that circulating growth hormone, but it shouldn't affect size of fibers.
All right, there's a question from, who has the phone? Sorry, go ahead.
To use an analogy, when a new drug is being tried in small controlled trials, it often appears safe, but sometimes when it's used more widely, side effects, sometimes rare but serious, are discovered. I'm wondering if we have enough experience with enough cases to know what the potential complications are, either just in general or perhaps in specific situations such as post-operative use.
Good point. Jeremy, you want to go ahead?
I think it's a great point. And I think that that's where this individualization of pressures and making sure we know exactly what stimulus we're applying, I think really plays a role. So I think I agree completely. So I think with some of these people that are immediately post-op, me personally, I don't know that I would say that we have enough evidence for that, but I think we need to get it.
Yeah, go ahead.
Yeah, I wonder, do you think there's a role for this blood-restricted training in athletes who can actually perform heavy strength training?
Mm-hmm. There is, yes. And there are quite a few studies demonstrating that not only muscle size can be increased more than, or on top of that, you can achieve with regular heavy resistance strength training, but actually sprint performance and other functional measures can also become even more enhanced as a result from that. There's a quite nice review out on the effect of blood flow restriction in athletes, and I think it's 2 years old or something like that. Yeah.
So you would do that on top of the normal heavy strength training?
I would combine it in very restricted periods of time, not too much. Few weeks, and combine it. Mm-hmm.
Now, Jeremy, you started out by saying that this phenomenon, with training, is very popular in the United States, and I can say that it has become very popular in Denmark as well, in the fitness environment and strength training environments around. Now, you talked about calf width and calf material and cushion pressure, and that's some details that we are very much aware about as scientists, as we are, and we are as well to some degree in our studies. But when I see people using this training methods around, and it's a lot of people, they use elastic knee bands, they use various kind of straps that you just strap on, and some of them leave them on for an entire training session, which is maybe an hour or so. Aren't you afraid that we have created a very, very popular phenomenon that people has wildly adapted without being aware of the consequences, and then we could actually have a lot of potential damages around with people who don't know what they're doing?
Oh, absolutely. But I think that potential exists in everything. But there is some data on the elastic wraps. There is some acute data. We did some of that probably about 10 years ago. And there is some chronic data in healthy people. Now, taking a person post-surgery and applying elastic knee wraps where you don't know the pressure, I do think that's a problem. But yeah, as the popularity rises and people start using it more and more, are people, I mean, are they at risk for using it inappropriately? Of course. But that's just how it goes, I guess. Education.
And then also making sure that this is not the general exercise tool you want to recommend for everyone, not even in the fitness. So I think a safe place to develop this would be in this clinical setting, which we have here. Physiotherapists, medical doctors, and exercise physiologists working with patients, and maybe some groups of frail patients. I wouldn't, on a general basis, recommend this for old people or young people, or unless you have an athlete who has kind of plateaued in muscle size and can't really get further, but knows that he or she wants to put on another 2.5 kilo.
But we can't really control it. I would say that there are probably thousands, maybe even 10,000 of people in Denmark around the fitness centers, fitness environments that are using this. So do we have kind of a responsibility to
I guess we have,
let them know what they should be doing?
I guess we have. So I think probably what Jeremy is doing, at least what I'm doing, every time I talk to the television or the journalists making popular features in magazines about this, of course I mention safety as the first thing. So if you put on a strap and you keep it on for more than 25 minutes, you have a high risk of making serious injury to the tissue in there. I mean, if you are depleted for oxygen for that long. And so somehow we need to make that come across every time we provide public statements. And beside from that, education is what you said. I don't know what to do.
Yeah, I don't know, I mean, how much more we can do. I mean, you have people wearing masks, suffocating on CO2, thinking they're training at altitude. I don't know there's much we can do to help these people.
It's 6 o'clock, and